Hi all. Today we are going to discuss about some important basic practical points. So, how many nodes in body they ask? If examiners ask, it is around 800, and in neck it is 300, in axilla it is 100, in abdomen it is around 250 to 300, in inguinal region it is 100. And very important point: what is definition of cross fluctuation? It is the fluctuation between the two separate cystic swellings that communicate with each other. Examples: plunging granula, psoas abscess, compound palmar ganglion. Pseudo fluctuation contains no fluid, it failed to expand in other parts of the swelling. Examples: large lipoma, myxoma, sarcoma, fibroma. So what is fluctuation? It expands in all the direction, contain the fluid. Example: cystic swellings. Carotid aneurysm is expansile, carotid body tumor, transmitted pulsation. In TB, there are 5 stages: stage of infection and lymphadenitis, peritonitis with mating, case-sheeting necrosis forms cold abscess, and finally cold abscess formation. To say a TB ulcer under bandage, bluish epithelium, seropurulent discharge, I made a separate video for tuberculous ulcer. So we need to move to the secondaries neck related practical points. So what is VARF? It is worrisome anomaly related to FNAC. So if this is present, even single lymph node is present, we have to go with excision biopsy. Never do FNAC. Radical neck dissection. So structures removed: fat, fascia, nodes, and if 2 nerves, spinal axillary, cervical plexus, 2 glands, parotid tail, submandibular salivary gland, 2 veins, IJV and AJV, sternocleidomastoid and humoid muscle, 2 muscles, prevertebral fascia. So what is extended radical neck dissection? So radical neck dissection plus full parotid, external carotid artery after it gives superior thyroid artery, tip of mastoid, mediastinal or retropharyngeal lymph node, hypoglossal and vagus nerve. So what is eddy current? External carotid artery ligated proximal to the superior thyroid artery. Because of this, thrombus forms. Intracaval embolism present. So what are all the complications of radical neck dissection? There will be both complications, but predominantly they will ask you on the left side. Because of thoracic duct injury, I made a video how thoracic duct drains into Virchow's node. If injured, if the tip is identified, then you need to perform lymphovascular anastomosis or lymphatic intern anastomosis. If not identified, then en masse ligation of the structure. A very important dreadful complication in radical neck dissection: carotid artery blowout. Because of the flap necrosis, we need to prevent by levator scapulae flap, use horizontal incision, avoid 3-point junction incision. You did IJV ligation. If you did on single side, there will be increase in ICP 3-fold. If bilateral, then 5-fold. So to avoid increase in ICP, use mannitol, lumbar drain, nursing patient in the sitting posture, avoid pressure drains.